Welcome to this presentation on the Integrative Physiology II. This is the second in this series of 3 recordings. And we'll continue with our consideration now primarily on electrolyte balance. And then there will be a third separate presentation from this lecture slide set even on the acid-base balance. Let's first then begin with the discussion of potassium balance. So there are regulatory mechanisms that keep the plasma potassium in a narrow range. Aldosterone, as we saw, plays a critical role. With hypokalemia, the low levels, the muscle weakness, and the failure of the respiratory muscles in the heart are the greatest risks. As we had stated in the first opening presentation, typically the muscle weakness, the fatigue, is the first clinical presentation of these symptoms. And then, of course, quick blood test, and you can see that the potassium's low. Then you know that there's a risk of the other two based upon how low it is. The hyperkalemia and other history and clinical tests that you run right there, of course. But anyway, the physical exam, too. The hyperkalemia, on the other side, can lead to cardiac arrhythmias, and because you don't have some early sign, this can be a bit more risky and dangerous. The causes include kidney disease, diarrhea, and diuretics on both of these sides, and we'll see how that comes into play. While the behavioral mechanisms are related to regulating this, drinking will replace the fluid loss, and of course with cognition, drinking appropriate types of fluids to contribute the electrolytes to balance what may have been lost is important. The low sodium stimulates salt appetite. We had kind of alluded to that before, but that's emphasized here. The avoidance behaviors help prevent dehydration. Desert animals will avoid the heat. They're typically a little more sensible than humans. They'll push themselves and end up quite ill because of heat exhaustion. It's important, just to back up for a moment, that typically the salt appetite will drive us to sources of potassium as well, as in addition to other minerals. So it's through this one mechanism, again, the focus on the sodium, that contributes to the behavioral processes that have been selected for evolutionarily, and what humans are famous for is over-cognating evolution and creating problems for themselves. Whatever your stand is on evolution, whether you want to call it creationism, we overshoot it and we cause problems for ourselves. We overcognate, I guess. Okay, the disturbances in volume and osmolarity are considered on this slide. So we have volume on the left here and osmolarity on the top, and we see a decrease and an increase, so no change and a no change, and an increase and a decrease are what we're crisscrossing in this matrix. So in the center of our matrix we have no change in osmolarity with no change in volume, where we are at a normal volume and osmolarity. So this box and a slight fringe around the edge of it, right, are the realm in which we should be staying under normal conditions every day. If there is a decrease in osmolarity, that is accompanied by an increase in volume, that might be generated by drinking a large amount of water as the cause. For a situation where there would be no change in osmolarity, but an increase in volume, that would mean that you'd ingest a large amount of the exercise drinks when you're not really exercising. right? So if you just drink a liter of water, you will increase volume and decrease osmolarity. But if you drink just a ton of Gatorade, a liter of Gatorade, you'll get no change in osmolarity, most likely, as long as it's isotonic. I'm not so sure that it's isotonic. And you will get a corresponding increase in volume. So the body has to respond differently to this than just drinking a large amount of water. If you drink a hypertonic solution, just a bunch of salt water, you get both an increase in volume and an increase in osmolarity. When you can experience a no change in volume but a decrease in osmolarity, this would be where you would replace what was lost due to perspiration with water. So it would be a case where you should have consumed an exercise drink like Gatorade. There are many others, as you know. Just because I say Gatorade, it's the only one I think of from watching too much football, I guess. But anyway, doesn't mean that I drink it or, that typical disclaimer. Anyway, if you don't replace what you lost, then you can have too much water, and that's not a good situation either, especially if you've been pushed to the limit with the extreme physiology. And of course, our famous bag of chips and soda, high sodium soda, eating salt without drinking water, would increase osmolarity and possibly not change volume. And then decreasing volume with a decrease in osmolarity, that incomplete compensation for dehydration. You don't drink enough water, or hemorrhage. Or the increase in osmolarity with a decrease in volume through dehydration, such as the sweating or excessive perspiration, sweating, right? Or diarrhea, and even excessive diarrhea. Yes, with one diarrhea event, you shift in this direction, but you still can be in the sphere of being able to come back to normal quite easily without a major change in behavior. But with excessive diarrhea, repeated, the backdoor trots as they're called, where you're really going back and forth, then you have to be consciously aware of what you must replace to pull back into this normal range. So it is a balance between solutes and solvent to be in this normal range, and changes in one or the other independently or together that will take you in any one of these directions, and the corrective action has to follow a similar path to come back into the normal range. So eating salt without drinking water has to be corrected either by drinking water and then eliminating the salt and the extra water to get back to here, or getting rid of the salt and saving all the water you can to come back here and have the normal volume and a corrected amount of salt. So if you do eat chips and drink a high sodium soda, and you don't drink water, then you have to conserve your water. Antidiuretic hormone will increase dramatically, and the mechanisms, the natriuretic peptides, will have to get rid of the sodium. So you retain all the water you can, you get rid of the sodium to come back to normal volume and osmolarity. So the same thing, you have to have a reversal, and if it isn't appropriate, you create another offset situation. So this water homeostasis can be seen in an animation if you have that slide. CD. So thinking again of volume and osmolarity, there's that tremendous interplay. So there are responses triggered by changes in volume, pressure, and osmolarity. So we can consider a stimulus as a decreased blood pressure or volume, and what would be the direct effects, and then some reflex responses to adjust to this change. So remember, we always think of baseline things with a little bit up and down. There's a tolerance range. And then along the way, we're going to think of some perturbance. So how do you perturb the system? Either In this case, we're talking about a decreased blood pressure and decreased volume somewhere during the day, and then how is it corrected to get back to homeostasis. So we'll think about the organ or the tissue involved, then the responses, and then the figures scattered throughout the presentations that we have seen for this organ system, and even from other chapters or other lecture series, because this is integrative physiology II that we're talking about now. So the decreased blood pressure volume would have the direct effects on the granular cells of the JG apparatus, the juxtaglomerular apparatus, to have a change in renin secretion, and then the glomerulus we would see a decreased glomerular filtration rate. So the renin secretion would increase angiotensin II, would decrease the blood flow to the glomeruli, and bring about a decreased glomerular filtration rate. The reflex response that we would see is that the carotid and the aortic baroreceptor reflex would be impacted, such that the cardiovascular control center is going to increase the sympathetic drive, decrease our container size. Remember, we dropped pressure and volume, so we want to decrease our container size. And then over here, we're trying to retain our volume of the fluid in the container up above here. But also the renin secretion, the angiotensin II, is going to contribute to the decrease of the container size. So the increased sympathetic output will cause vasoconstriction. The increased angiotensin II will contribute to that as well. And then there's going to be so we're going to put our foot on the gas pedal and take our foot off the brake. So there's a decreased parasympathetic output. And remember how these two would have their interplay on controlling heart rate. So we want to affect heart rate, stroke volume for cardiac output, and then total peripheral resistance for blood pressure. Remember our mean arterial pressure formula, MAP equals CO, which is heart rate and stroke volume, times the TPR, the total peripheral resistance. So that's all embedded within this discussion here. And when you see increased renin secretion, you think of increased angiotensin II, it's going to contribute to those factors as well. The cardiac and the aortic volume receptors are going to signal the hypothalamus that we need more volume, so the behavioral response will be triggered. The carotid and the aortic volume receptors will also impinge upon the hypothalamus, diverging within the hypothalamus. So here we see these convergences of all these systems onto the hypothalamus, but once there, they diverge, so they all come into the hypothalamus and then diverge internally to go to thirst area, the vasopressin neurons. And then now here we're going to target the reduction of the container size through the vasopressin name of this hormone, and then through the antidiuretic hormone we're going to contribute to this effect on the kidney. So we'll decrease the filtration rate, but whatever gets filtered, we're going to draw back all the water that we can. So this combined effort to retain all the water that we can. And then the atrial volume receptors converging on the hypothalamus with these other ones, and then diverging within as well to the thirst stimulation and the vasopressin secretion centers. So if these receptors are not being stretched enough, then they'll drop, their firing rate will drop below basal levels, and they're going to send neural signals ultimately to a thirst center to say you need to drink more to increase your volume, and you need to release the vasopressin to contribute to the reduction of the container size at the same time that you retain as much water at the kidney as possible. Now let's switch over to the other side. You suddenly have an increase in blood pressure. The direct effects at the glomerulus will be an increased glomerular filtration rate, although the autoregulatory mechanisms will typically make this a transient effect. The myocardial cells will contribute the natriuretic peptide. We're going to try to reduce volume of the liquid within our container, and we do this by driving sodium into the urine. Water will tend to follow it. Reflexes, the same. We have the carotid and the aortic baroreceptors and the atrial baroreceptors. These are the stretch receptors detecting the amount of pressure, and indirectly volume, right? So volume, pressure, and stretch are all interrelated where these receptors are located. The carotid bodies, the carotid sinus, the aortic arch, and the atria. So higher volume, higher pressure on the wall, higher stretch the receptors, they increase their firing rate, and the cardiovascular control center in the medulla is going to be affected. Here now we're going to take our foot off the gas pedal, decrease sympathetic tone or drive, and then increase the parasympathetic. We're going to put our foot on the brake. So we want to bring heart rate down. These two opposing effects, taking our foot off the gas pedal and stepping on the brake, will decrease heart rate. You will decrease total peripheral resistance by taking your foot off the gas pedal to the smooth muscle cells, so they will relax, and you will increase the size of the container. So we are decreasing the volume of the fluid here. We are increasing the size of the container here, as well as changing the parameters for mean arterial pressure, cardiac output, which depends upon heart rate and stroke volume, and the total peripheral resistance. As well, we're going to inhibit thirst, and we want to shut down the vasopressin for two reasons. We want less of it to relax our container, to let our container get bigger, and also we want to decrease the amount of water that it is bringing in at the kidney, so we can decrease the volume within our container as well. Now let's consider increased osmolarity. Well, the direct effects are going to be a pathological dehydration that will trigger directly at the adrenal cortex a decreased aldosterone secretion. So this is not the typical type of thing that you encounter on a regular basis. As we talked about, you can have a bag of chips and a soda, or any type of a meal that will alter osmolarity. Remember our table. Anything that will alter osmolarity selectively is something we can encounter and manage during a day, but at an extreme pathological dehydration, then the adrenal cortex is going to be stimulated potently. So under normal conditions, daily swings in our osmolarity because of ingestive behaviors or other kinds of behaviors like working in the heat and losing too much liquid, then we normally will not see the adrenal cortex stimulated. It's just when it is in a drastic extreme. Under the reflexes, we will see the osmoreceptors in the hypothalamus being triggered, and then there's interneurons that will diverge away from that central osmoreceptor region to the behavioral region, the thirst region, and it's going to tell you to drink. And in these cases, it'll drive you toward water, and then vasopressin secretion is going to here more so have the selective effect on the kidney. Yes, it will bind to its receptors on the vasculature and increase the tone, or increase its contribution to the tone, but other mechanisms will be in play to minimize the vascular effect of the vasopressin. And so we kind of take that one out of the picture by local mechanisms at the endothelial cells, and then we preserve the desired effect at the kidney to retain all the water that we possibly can to dilute out the solutes. Remember, we're talking about increased osmolarity as our condition. If we go in the other direction, a decreased osmolarity, then we are thinking about a situation of a pathological hyponatremia as a common condition. So we dilute out whatever sodium is in our body. So it is, therefore, a pathological hyponatremia. And the adrenal cortex, in this case, will increase aldosterone secretion. Remember, aldosterone will resorb sodium at the expense of potassium. So if you dump too much potassium, you get a hypokalemia. So if this pathological hyponatremia results in a pathological hypokalemia as part of the corrective action, then you can have a cardiac event. And then the reflexes, the osmoreceptors at the hypothalamus, will decrease the vasopressin secretion. So you want to eliminate the drive at the kidney to have those open water channels. You want to pull them out of the apical membrane and just stop taking back any water and have the most dilute urine possible. So obviously volume and osmolarity go hand in hand. You can increase volume and dilute out your solutes. You have to respond in a certain way. Or you can increase osmolarity and cause the increase in the intake of water and increase volume through that means. So if you swallowed a salt tablet, it would make you very thirsty. You'd drink a liter of water. Before you can correct it, you're going to have an increase in volume, right? So the homeostatic compensation for severe dehydration is what we're considering on this slide. So this would be someone who's been out in the heat without water for long periods of time. Doesn't just have to be heat either. It can be conditions of cold, freezing cold temperatures, but the water intake doesn't match the water loss by whatever mechanisms you're losing it in a cold situation. And if it's if you're trapped out in the cold for 3 days and you have no water, you can get just as dehydrated as maybe not as quickly as in a desert. And so this reminds us that if, regardless of how you get there, the end point can be a severe dehydration. So it can happen in cold conditions where the water intake doesn't match the water output, or in high temperatures. So the drop in the blood volume will be paralleled, of course, by the corresponding drop in blood pressure, and this would be accompanied by an increased osmolarity, concentration of the electrolytes. So we're talking about a situation where the water input falls below the water output, so the electrolytes are becoming concentrated in the body fluid, so there's an increased osmolarity. So this blood pressure, blood volume change is going to have the effects on the granular cells, and it will be a stimulatory effect to activate the renin-angiotensin system so that we get the adrenal cortex recruited. And the angiotensin 2 is going to have effects on the cardiovascular centers in the medulla, and direct effects on the arterioles, and effects on vasopressin release from the posterior pituitary, and it's going to stimulate the thirst drive. And of course, if you're in a desert or in a freezing area, you're not supposed to eat the snow to get your water because it can really mess you up otherwise. But anyway, if you can't satisfy this, then the problem persists and it can lead to pathological situation. So we went first straight for the renin-angiotensin system. Let's now follow this branch here to the cardiovascular mechanism. So the carotid and the aortic baroreceptors, of course, at the medulla, are going to lead to the stepping on the brake to taking our foot off the brake, decreasing the parasympathetic output to allow heart rate to increase. Remember, we want to increase cardiac output, so we put our foot on the gas pedal and take our foot off the brake, and we increase the sympathetic drive to the heart, increasing heart rate and contractility, the force, both of which will increase cardiac output. And then we will contract the arterioles with the sympathetic drive, enhanced by the effect of the angiotensin II, leading to vasoconstriction, increased total peripheral resistance. So cardiac output times total peripheral resistance will increase the mean arterial pressure. So we're compensating for the drop in blood pressure. We have decreased the volume of our container, and some of the dynamics of generating the forces against the walls of our container, right, with the effects on the heart, cardiac output. And now we can go to the renal mechanisms to decrease glomerular filtration rate. Remember, we want to preserve volume, so we don't want to filter as much, so we are conserving volume. And then we decrease flow at the macula densa, so that also is going to have a stimulatory paracrine effect on the granule cells. We forgot to talk about our sympathetic drive there also converging to enhance the renin-angiotensin system, as well as the sympathetic, the gas pedal, causing the constriction at the afferent arteriole to decrease glomerular filtration rate, as well as constriction of the renal arteries themselves to decrease renal blood flow. That will also contribute to a global drop in glomerular filtration rate at the kidney. Then the hypothalamic mechanisms, we're going to get atrial volume receptors and carotid and aortic baroreceptors impinging on the hypothalamus through a multisynaptic circuit, as we had mentioned, driving the vasopressin release from the posterior pituitary, so adding to the effect of the angiotensin II. The impingement on the hypothalamus also will activate the thirst center. The osmolarity itself will have the effect on the hypothalamic osmoreceptor and contribute to this integrated response, both on the vasopressin release and the thirst drive. And then the vasopressin has that effect on the distal nephron to conserve on volume as well by increasing the water reabsorption. The thirst, if it can be acted out, will contribute to water intake, and this, of course, will dilute out the solutes and recover the osmolarity, but also contribute to the volume recovery so that we have normalized blood pressure. They broke it out like that. Anyway, I did it all together. You can look at it separately. The acid-base balance is considered in a separate presentation. So this completes this presentation. I appreciate your time and